Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. Those on this podcast accept no liability for the outcomes of medical decisions based on this information. As the radiologists like to say, clinical correlation is required. This is not medical advice, and this does not constitute a physician-patient relationship. If you have a medical problem, seek medical attention. And now, here's Dr. Bradley Block.
And now a word from this week's sponsor, Laurel Road.
Taking out med school loans had me watching every penny. I took 2 buses to get to campus. During my residency, I walked 20 blocks. But since I opened a Laurel Road linked checking account when I refinanced my loans, I got a crazy low rate plus a cash bonus. And all that extra money helped me finally buy my own car.
Where are we going?
Anywhere we want.
Laurel Road for Doctors. Banking, insights, and benefits uniquely designed for doctors. See laurelroad.com/doctorchecking for full terms and conditions. Laurel Road is a brand of KeyBank N.A. member FDIC.
Dr. Karen Wolowick, thanks so much for coming on the podcast.
Hi, Brad. Thanks for having me. I'm so excited to be here.
So let's get right to it. Give us a crash course in birth control. Go.
You got it. See, everyone's so excited for an episode with a gynecologist now, right? So let's make it quick and easy. So birth control options, just a few here. So good old-fashioned birth control pill. It has been around forever. Sometimes it gets a bad name, but it is literally one of the best things ever invented. So birth control pill, worst thing about it, you just got to remember to take it every day. That is the only way it works. And that's the only way you're going to feel good on it, but you got to take it every day. For those of us that are bad about taking it every day, there is a patch that you can wear that you just have to remember to change once a week. So that's not so bad. Or the Nuva ring. It's a vaginal ring, literally a little plastic ring that sits inside the vagina. Just remember to change that once a month. Pill, patch, Nuva ring, they're all little estrogen and progesterone. Keep your hormones nice and balanced. Lots of good benefits besides just birth control. Other options for birth control, though, there's...
the Nuva ring.
Yes.
So is that the way that works? It's a ring that sits around the vagina to prevent penises from going in? Is that how it works?
Not so much. No.
Okay.
So it's a little vaginal ring. It sits inside the vagina.
Okay.
It's like you can't feel it. You don't know it's there. It's completely removable. It contains the same hormones that are in the birth control pill. So it's a little estrogen and progesterone. Instead of swallowing it, the hormones are absorbed through the vaginal mucosa. It still gives you systemic estrogen and progesterone.
Okay.
Again, keeps the hormones nice and balanced. They all work to prevent
self-applied
ovulation. Yeah, women can take it in and out themselves, absolutely. But prevents ovulation. That's how the pill, patch, and Nuva ring work. So all good things. Other options, Depo-Provera shot. That's an intramuscular injection of progesterone that you get every 3 months. This one has probably the most side effects, a little bit of weight gain, a lot of irregular bleeding for the first 3 months. I mostly use this just for my non-compliant teenagers, but still safe and effective. And then everyone needs to know about IUDs, intrauterine devices. These things are fantastic. There are 5 different types of them. They're so great for birth control. They last anywhere from 3 to 10 years, depending on which one you get. And there are 4 of them that contain progesterone that also help significantly with periods, which is fantastic. There's also a little Nexplanon. That's a little subcutaneous arm implant. Contains a little progesterone, good for 3 years. And of course, we've got tubal ligations and vasectomies for those people who don't want any more kids or never ever want kids. Those are good options as well too.
So this is getting a little further afield than we had planned on it, but you mentioned IUDs, and I had read that, with the changes in abortion, Roe v. Wade, that women were going to get IUDs, like there was a rush on IUDs.
Oh, yes.
And that's because they wanted to prevent themselves from getting pregnant, not because there's a chance that IUDs could somehow become illegal?
Oh, gosh, hopefully not. IUDs are fantastic forms of birth control. They are safe, they are effective, they are great at preventing pregnancy. There is this misconception out there that they can somehow cause abortions, and that's really not the case. Some of the progesterone ones do thin the endometrial lining a little bit. They do work by preventing implantation as well a little bit, but the main mechanism is they prevent pregnancy in the first place. They're toxic to sperm. They prevent the sperm from ever meeting the egg in the first place. So it's really important to know that they don't cause abortions to happen. They prevent pregnancy in the first place. And I think that was the worry about why they might get banned, is just that, that kind of misinformation that's out there.
Got it. Okay. What misinformation do you hear regarding birth control? Right. So I'm an otolaryngologist. It's not something that's part of my continuing medical education. So there might be other physicians out there that haven't learned about birth control since they were in medical school. Maybe they heard something, repeated it to a patient, and then it comes back to you that the patient heard this from a doctor, right? So is there misinformation about birth control that you've heard your patients say that sounds like it may be coming from physicians or other healthcare practitioners?
Well, I hope it doesn't come from physicians. Certainly, there's so much misinformation out there. Most of my patients are getting their information from TikTok now. I mean, it's all over social media. So much misinformation.
I thought I'd never be on TikTok, but I might have to. I mean, if that's where they're getting their information, we got to go where the audience is.
We got to go if that's where they're getting it. So,
next episode, Dr. Wolowick, we're gonna have to have little sign, and we're gonna have to start pointing to instead of talking. I'm going to ask you a question, and you're going to point to the answer.
Exactly, but I think we've got to. You got to write the words out. But I a patient today, so she follows an influencer. I guess on TikTok, Instagram, I don't know what, but they promote this idea that that hormones are bad, and that birth control pill isn't safe for you. And this just could not be further from the truth. So this whole idea that hormones are bad is really just sexism. It really is. Estrogen's good for you, coursing through our body. It's okay. A little estrogen and progesterone, there's nothing wrong with that.
Not only wrong with that, right? It decreases your risk of heart disease. Once those things, we even tried replacing it with not good outcomes, but yeah. So they're
very good benefits to estrogen. And this idea that all natural is safe. So anything natural must be safe for you. Anything made in a lab is not safe, is completely false. The biggest thing is pregnancy is much more dangerous for you than the birth control pill. I promise. Risk of strokes, heart attacks, high blood pressure, all of that way, 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 way higher in pregnancy than from taking a birth control pill. So we've got to remember that. We've got to stop this misinformation that somehow something that is natural is automatically safe for you. Not true.
We had an episode, actually a couple episodes a long time ago with an evolutionary biologist, Nathan Lentz. And one of the things that we talked about was pregnancy in humans and how the mortality is so high. And it turns out that these giant craniums that allow us to become the dominant species on the planet are also a huge liability in terms of maternal mortality. But it in terms of evolution, the risk versus benefit for the survival of the species was there. On an individual level, it's dangerous. It's dangerous.
It is dangerous. It gets completely glossed over. I mean, there's a whole specialty just helping women get through pregnancy. And most of my colleagues and myself, we see really scary things sometimes. And at the end of the day, we just say, well, thank goodness they're young and healthy, because that's really why they survive some of this stuff. So pregnancy can be quite dangerous, not to scare people out of it, but the idea that the birth control pill is somehow dangerous for you and pregnancy isn't is completely wrong.
If we're scaring people out of it with this conversation, then they probably shouldn't be. They haven't thought it through well enough, and maybe should sit down and think about it.
It's true. It's so naive. Oh, it's just, it'll be so cute. I get a little belly, it won't be so bad. One cute little push, and then I'll have a baby. Yeah. We're not, we're setting ourselves up for a disappointment. No doubt about it.
Exactly. Not just because your influencer showed you all the amazing things about being a parent.
Oh, yes.
Okay. So whenever I put someone on antibiotics or steroids, in my specialty, usually both, the EMR tells me that it interacts with the birth control, right? So what should I be telling those patients? Should I be telling them, stop the birth control or keep going? It's just not going to be effective. or, what is it I should be telling my patients?
Sure, sure. Well, yeah, I'm never going to tell you to tell them to stop the birth control pill. That's for sure. So really, those interactions just mean that instead of your birth control pill now being 99% effective when taken correctly, maybe it's 96% effective, maybe 90, at the worst. So still 90% effective at preventing pregnancy. So you let your patient know that, hey, this might decrease the effectiveness of your birth control pill a little bit. So you've got to be really good this month about taking the same time every day. You might have a little breakthrough bleeding or spotting. And if you're going to be sexually active, you definitely want to use a condom this month. That's all, just a little backup, but no reason to stop the birth control pill.
Okay. Okay. Great. That allows me to have a little more informed conversation with those patients rather than just abstinence while you're on your antibiotics. While you have a sinus infection, snot is just pouring out of your face. You might
Definitely
not
talk
want to.
about sex with your patients.
Yeah,
They're going to
yeah.
appreciate that. You're going to want to
Yes.
ask them, get personal. Yes.
So what about the clotting risk with
Sure.
birth control? And is it's with the birth control pill, or is it with all of the estrogen containing birth control
You
methods?
got it. So it's always estrogen that's blamed for the clotting. So that's your birth
Wait
control.
a second. We just said how amazing estrogen is. Now it increases your risk of clotting?
Sure, I still love it. But yeah, it's your birth control pill, the patch, or the NuvaRing that contains a little bit of estrogen and progesterone. Risk of blood clots, strokes, heart attacks, all that bad stuff on that is literally less than 1 in 1,000. And those 1 in 1,000 women are usually over the age of 35 who smoke, or people with a family history of blood clotting disorders, your factor V lines, your prothrombin gene mutation. So again, risk of blood clots in pregnancy, about 1 in 500, much higher in pregnancy. But overall, so a slight increased risk, yes, but it's not 50%. It's not 1 in 2. It's nothing to be too worried.
Now, I don't want to name this specific illness. I'm going to spell it. And the reason is because when we put out YouTube videos, if we mention it by name, they don't let us push it out. COVID, right? Because they just assume that anyone who's creating a video about it is creating misinformation. So they don't let us put it out there. So this is a virus that causes endothelial damage. We're seeing
Sure.
increased risk of heart attack and stroke afterwards. So are you seeing that there's any type of interplay between birth control and the virus?
I have not seen that personally. I've not seen that clinically. Theoretically, sure, there probably is, but there's a lot of modifiable risk factors for blood clots. Smoking, immobility, obesity, high blood pressure, all of that stuff has to play into it as well.
Got it. Okay.
So,
And now sorry, go ahead.
I was just going to say, and there are other options too. So, if we feel like this isn't a good patient, to be on estrogen, say that we know she has a factor V Leiden deficiency, she's immobile, she's obesity, she has high blood pressure, maybe she's not great for estrogen. There's still lots of other birth control options out there. So, it's not that there's no option for her whatsoever. There's lots of other great options.
But all about risks versus benefits. Yeah.
Exactly.
Okay. So we talked about how amazing estrogen is.
Yes.
When should our patients come in to have their hormones checked?
Oh my God. OB-GYN's least favorite patient, and we see them every day. They usually read it online. I've come in, I feel off, I want my hormones checked. And again, so anyone who's been to medical school knows that your hormones fluctuate throughout the menstrual cycle day to day. So as we remember, in the beginning of the menstrual cycle after period, estrogen levels start to increase. They peak mid-cycle at ovulation. You ovulate, you form a corpus luteum, which releases progesterone. That peaks about the 3rd week in the menstrual cycle, and then those hormones all decrease and crash, and that's what signals the period to come. So as we know, in a normal menstrual cycle, hormones fluctuate day to day. So checking progesterone and estrogen levels on a normal premenopausal woman is not helpful in any way in determining what's going on with her.
I think those patients often, it sounds like those patients are like the brain fog patients, right?
Completely.
They come in to see me sometimes because they're like, it's my sinuses, and they'll point to their sinuses and just be like, it feels congested. And it's just this vague sense of fullness that is really affecting their quality of life, but hard to pinpoint more than that. Or they'll say, it's my allergies. And really they're describing the same symptom, or they'll say it's more like dizziness and they'll think it's coming from their ear. So
Sure.
just, these patients are not just going to see the OB to have their hormones checked. Like they're really often in a challenging situation where, because it's so hard to characterize the symptoms, it's hard to know where to send them, what to check, what to do.
Absolutely. This is the same. I'm sure the primary cares, it's the same. I want my thyroid checked. I need a thyroid panel. I know it's my thyroid's off, because patients often complain the same thing. It's true. Fatigue and, fogginess.
With the concentration. Yeah.
Yeah, all the time. So unfortunately, these patients just take a little while. You've got to sit down and talk to them. The first question I ask is, how are you sleeping at night? Almost all the time, they're not sleeping well at night. As as doctors know, sleep deprivation is evil. It's everything. You cannot function when you're not getting a good night's sleep. It catches up with you eventually. Even if you think it doesn't, it does. You can't remember anything. You can't form words. Everything's harder. You're gaining weight. You can't lose weight. All of it. So sleep is number one. And then we talk about diet, exercise, and other causes of stress, so you got to kind of go through that. You tease all that out. It's tough. Everyone's looking for
Dr. Wolowick, you're not going to achieve influencer status if you're just saying sleep better, eat better, exercise. Yeah.
Yes, I know. And honestly, and you see them being disappointed because they were so hoping that I would just say, here's the supplement you need. I've got it right here on my shelf. I'm ready to sell it to you. 20 bucks, or more than that probably. But that's the secret. And we've always known this, right? Sleep, diet, exercise, and stress levels.
And if any of the listeners know someone that can help us to help the patients do all of these things. Like I had BJ Fogg on the episode on the podcast a while ago talking about habit development, but anyone else in the field of habit development that can help us get those patients to sleep better, eat better, exercise more, because it's easy to say it, it's impossible to do. So
100%.
yeah.
That's where the frustration comes from, because we've only got a little bit of time with them and we're talking about making lifestyle changes. Yeah, so I do try to break it down exactly like you said, your daily habits. It comes down to your daily habits, and you've got to prioritize, what's most important. Yeah. Easier said than done.
Yeah. Okay. So let's talk about pregnancy now.
Sure.
Right? Because there were, or maybe there still are, maybe I'm wrong, medication classes in pregnancy, right? I knew what class A, B, C, and D, right?
Sure.
I knew what those meant. Are we still using those classifications?
I don't know. To be honest, us OB-GYNs, we always hated them. They didn't mean much to us. Oh gosh, yeah. Because really, when you look at them, all it means is, well, it's not well studied, but probably safe, or it's not well studied and probably not safe. And
but I can explain that to a patient. Like that's a bite-sized bit information that I can be like, listen, it's been proven to be harmful, so we can't use it. This one has never been shown to be harmful. You give it to a large dose, in a rat, and it causes problems. But in humans, it's never been like I found that it was a digestible way to break it down. So you're saying I shouldn't be using that anymore?
No, because even still, like, it has never been proven to be not safe, doesn't mean that it's safe. So it all comes down to, does the woman need to be on the medication or not? It's as simple as that. So if she needs to be on it, she needs to be on it. If she doesn't, then she doesn't. It should have nothing to do with whether she's pregnant or not. Now, certainly there are some medications that will, like blood pressure. So we like labetalol, which is a nice, gentle little blood pressure medication, whereas an ACE inhibitor is not what we would pick in pregnancy. But you don't make decisions about whether or not she's on the medication just because she's pregnant.
Right, but it helps me choose antibiotics. Right, it helps me choose like Augmentin is class B and like Levaquin is class D. So, right, this helps me.
Yeah,
this helps me.
Sure. Okay. So yeah, I'm happy with that.
Okay.
Yeah.
Otherwise
But even one dose of Levaquin, I'm not going to like lose my mind over as an OB-GYN. Really, it's chronic medication. So
you know what I'll do?
You can't take one every day. That kind of stuff.
Anytime I'm going to prescribe a medication to a pregnant woman, I'm going to call her OB and ask first.
Oh my God.
Okay, so don't do that.
Please do not. Call the pediatrician for it. I'm kidding. No one's engaged for that. No one. So yeah, no worries. It's just risk benefit. You got it. Antibiotics, you have your handful that that will work for what you're prescribing, that are safer in pregnancy. You're going to use the lowest dose possible for the least amount of time, but you would do that for any patient. That's okay. Yeah.
Okay. Okay.
Yeah, it
Okay.
takes a
You make
lot
it
to get
sound
an
so simple.
OB-GYN excited about medication. I mean, we see people on heroin and cocaine. I mean, it just you have to really impress us to.
Yeah. 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 But I just remember the pictures of like the digits of kids
Mm.
of from medical school. Like those pictures, they stay with you. Like the
Sure, sure.
strangulated fingers from avascular necrosis.
Yeah. You see a lot of
But
stuff.
but heroin, they were all fine, right? So that's how we know.
Right. Exactly. So it just doesn't work like that. It's not like you
Yeah.
take this once and bad things happen. It's usually chronic usage of anything and
Okay.
multiple risk
Okay.
factors. So sorry, I know.
Okay. Oh, I was hoping you could simplify it. Okay. Um. Okay. Okay. So same question, but with breastfeeding.
Sure. Yeah, same thing. Same thing. And breastfeeding, we're even less impressed because
Yeah.
even if things are in breast milk, they're often not even usually the active metabolites. So
Yeah.
like, I'm less impressed with that for sure.
Okay. Okay. I mean, often I can find like the breastfeeding information on the
Yes.
in the EMR, and it'll
Yeah.
tell me like, and 0.06% ends up in the breast milk. So like it's some like minuscule amount.
Yeah, you're fine with that.
Yeah.
Exactly.
Okay. Okay. So don't call the pediatrician with that question.
Yeah, maybe not. They get a
Okay.
lot of phone
Okay.
calls, I think.
Okay.
Yeah.
Yeah, they do, especially now. Um, okay. So let's talk about now the state of OB practice,
Oh,
right?
yes.
Like the evolution of OB of modern OB, inclusion of midwifery. And then actually before we get to the state of OB, midwifery, is there like a pre-wifery and a post-wifery that goes with the midwifery, or is it just
I've only
just
met the
midwifery?
mid. I don't know.
No,
Yeah,
no
there should be a pre and a
pre-whiffing.
post. Yeah, you should get to, yeah, graduate. I'm not sure,
Exactly.
but yeah,
I'm in
that would
my
be
post-whiffing stage. Yes, take a post back.
fun. Not sure why mid, but yeah.
Okay. Yeah, right?
Right,
Just mid.
right, yeah.
Uh, okay. So let's talk about the state of OB practice. And is there going to be anyone left practicing obstetrics, or is everyone just going to be like, you know what? I'm done.
Yeah, that's probably where
GYN
we're
only.
heading. That's for sure. Yeah, the days of, one doc doing everything all the time is the days of have to be numbered there. So, myself, I was part of a large multi-specialty physician group, and I was part of like a six doc practice, and we did everything. Unfortunately, we didn't have any midwives that we worked with, or some hospitals have laborists now, which is fantastic. They just deliver all the babies, also great, but we didn't do that. And I'm probably still part of the majority, but it's you're rounded in the hospital, you're delivering babies, you're in the OR, you're seeing patients in the office, we're doing circumcisions even. Oh my gosh, it's like when you're on call, it's just crazy busy. You never know when an ectopic's going to come through the ER. It's just nonstop. And I for sure, I did that for about 12 years, and then I got super burned out, super burned out. So I took a little break, and then I opened up my own private practice now, and I'm just doing gynae only, and it's been life changing. I feel like I have a part-time job. It's from what I was used to. It's just so much better. It's so much better. So I do feel like if we can compartmentalize some things, that may help a lot of us for sure. For
Well,
sure.
so the laborist thing I think is new, right?
Yeah, yeah, that's becoming very popular. It's a lot of the bigger hospitals. So, one of my former partners now is just doing OB hospitalist work. It's great. You do, a couple either 12 or 24-hour shifts, and you do,
24?
well, some still do 24 exactly, if you're
Ugh.
traveling, but you just maybe do two of those a week instead of, being on call as much as we were. And she gets to go home when she's done. It's beautiful,
And
you know.
is that when they do that, do they also have like an outpatient practice in addition to being a laborist, or you are a laborist? Like it's like being in the emergency department, right?
Right.
Like when you're on, and that's it. There's no like
Yep.
outpatient,
Yeah, no, you go home and
other
you're
component.
done. You don't have to see patients in the clinic. You don't have your pager on you. You're just done, which is a beautiful thing. Yeah.
That sounds really nice. And especially if you're employed by a large hospital, because one of the big downsides to OB is the liability. I mean,
Yeah.
not that
Yes.
getting sued is okay, but when the malpractice is being covered by the hospital that you're working for, it is a different situation because like you're in private practice now, like you have premiums, and if you get sued a bunch of times, the premiums go up. Whereas
Right. You
It
got it.
sounds like
Yeah.
it's a
Certain states
nice
are
system.
terrible. Yeah, I'm in Illinois, and it's crazy. It's six figures here for malpractice for an OB in Illinois. It's insane. It's really crazy. So yeah, getting that covered is no small thing. That's for sure. Yeah,
So, I mean, how is that sustainable?
it's not. It's not. I mean, it's just not. And it's, unrealistic that we, even in residency, you're just expected to do everything. And I'll be honest, a lot of us like the variety. I went into it, I really liked the variety. I loved delivering babies. I got to operate. I'd be in the office. I liked doing everything, but it's just, I don't think it's sustainable. Like it's exhausting, So I think it's fun to kind of do everything in the beginning, see what you like, and then maybe it is nice to kind of focus then after that.
Yeah, taper off from there. Yeah. Yeah,
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 for
yeah.
sure. Which is totally doable. Totally doable.
So
Yeah.
then how does call work for you now?
Well, I mean, technically, you could say I'm on call all the time, but not really. I never, knock on wood, get called by my patients. I'm just doing gynae only. There aren't a ton of emergencies there. I mean, sure, that can happen, but I have a patient portal, and with every visit, I encourage my patients to reach out to me through the portal directly. I'm like, it's HIPAA compliant, it's a private portal. That's how you get a hold of me. I check it a couple times a day. And I don't mind it. It's lovely, but I'm not getting paged constantly and interrupted constantly, and it's totally manageable. Yeah.
Sounds so nice.
It's so nice. It's so nice. They say private practice is dead, but I don't believe it. I just
No,
don't.
no, 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 no.
I really don't.
You are preaching to the choir here. I am in the private practice of private practices.
Yeah.
Yes,
It's
it
it's
is
been
alive and
amazing.
well.
Yeah, it's been absolutely amazing.
Okay, so we talked about some misinformation about getting your hormones checked, and some misinformation about birth control. I mean, is there anything else that you'd like, let's say you had a group of your referring physicians in the area,
Sure.
and you wanted to help them to be better referrers, either to work stuff up themselves, or you know, or before they send them to you, maybe tee the patient up a little more.
Sure. Sure.
What are some things that you'd like them to know?
Well, right now I'm happy you just send me your patients. I have my own ultrasound. I'll spend a half hour with them. It's lovely. But that's not how it was. Most OB-GYNs are part of a very busy practice, and they really do appreciate when you send the patient for the ultrasound first, order whatever labs you want to you want to get on them. Usually, you're at least checking a thyroid and stuff like that to make sure that that's normal. But yeah, we love when they come with the ultrasound in hand, and then we know which direction we're going, which way to talk to them about options.
What are we ultrasounding?
You want to look at the uterus and the ovaries.
Okay. 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 I'm just like, there's like a whole area here, right? And I don't know if when you order it, you order something specific, or just like the whole abdomen and pelvis,
Yeah, you send them to radiology, you say pelvic ultrasound. They have them fill up the bladder, press on the bladder while they take a look at the uterus and ovaries. And then they usually do a transvaginal ultrasound actually to get a better look at the uterus and ovaries. But
Got it.
what we're looking for are fibroids in the uterus, cysts on the ovaries, sometimes a polyp in the uterus. These things that cause abnormal bleeding, problem with the hormones, all that kind of stuff. So then you know what's going on first, and then you know how you're going to approach the treatment.
Okay. So less hormone checks, more ultrasounds.
Please, yes, much more
Okay.
helpful, much more helpful.
Okay. Well, and let's say you had a bunch of medical students that you wanted to make sure they're not going into OB, they're not going into anything related. They're like head and neck radiation oncologists. They're, otolaryngologists like me, right? Pathologists that aren't working. They have nothing to do with OB,
Yeah,
but you just want them to be good physicians, citizens of the world,
yeah.
conveying good information. What are some things you'd like us to know?
Yeah. Just that there are many safe and effective birth control options. And if a woman wants to go on and have an education or a career, she needs to be aware that there are so many safe and effective birth control options. There's so much misinformation out there right now. It's, please don't get your information off of TikTok and influencers. I told my patient today, if they're trying to sell you something, that's the red flag right there, right? They've got the supplements, she bought all the supplements. not where you want the advice. So anyway, so safe and effective birth control options. Birth control pill is safer than pregnancy. Let's remember that. And lots of good, reliable options. Women can have control over their reproduction. It's a beautiful thing.
Fantastic. Dr. Karen Wolowick, where can people find you online? Where can we find your practice?
Sure. I'm in the western suburbs of Chicago and Downers Grove, Illinois. I have my own little website, Wolowick Women's Health. And of course, I'm on Facebook and Instagram because you got to be now.
Wait, spell Wolowick for us.
Sure. It's Wolowick.
Just like you say it. Fantastic.
Sure.
Well, thank you so much for your time and all this great information. And it's been a pleasure.
Thank you for having me. So much fun. Thank you.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.